Welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Alzheimer's from A to Z, Memory Loss, Dementia, and the Basics of Alzheimer's Disease. If you have questions about anything discussed today, please call or email us during this broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will be able to register for this in order to get access to these materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While the content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on February 28, 2018, and for 2 years for social workers, expiring on February 28, 2019. I'm Jacqueline Giddens, nurse consultant with the Bureau of Home and Community Services at the Alabama Department of Public Health, and joining me today is Jason Young, Director of Programs and Public Policy for the Alzheimer's Association, Alabama and the Florida Panhandle. Welcome, Jason.
Thank you. Appreciate it. In looking over the target audience of who would be on the presentation today, I'm looking at a lot of professions that I've worked with a ton over the years, and when I think about the content of the presentation, I have no doubt that the perspective and the insight on Alzheimer's disease that you'll gain from everything I'm presenting will be helpful. Go back for a second and talk about perspective and insight. So much of what you learn about Alzheimer's ends up being ways that you help the caregivers and family members to learn more about what it is that they can do in response to things like behaviors, and knowing more about the disease itself to know what to do. It's not that we won't address how you work directly with people. We'll talk about that too. But so much of everything that you take in and information and something like this, and there's so much you can only take in an hour with a lot being thrown at you, probably the most important thing is gaining an insight into how you can change your approach and what you're doing to both working with the person with dementia, as well as how do you help caregivers with learning more about the disease. I guess I forgot I'm to be advancing the slides. To give you just a little bit about the background that I have, I've worked in inpatient and outpatient settings, in residential facilities where there's long-term care, assisted living, where I was a clinical professional doing a lot of consultation with the nursing staff in long-term care, and I also did inpatient psych assessments at a hospital. Working at the Alzheimer's Association has given me a chance to look at things from the public policy perspective. So in review, all those things gives me a perspective on the disease on many fronts, and I think that'll lend itself to giving you that perspective that I was talking about. This presentation is really, you could call it the basics, Alzheimer's 101 if you would. It goes into a lot of disease symptomology, but what you see actually on the slides, there'll be times when I only take 2 or 3 things that I think those are the ones that I really need you to walk away with something that you may not be able to from looking at the slides. So you can always go back and review slides and look at that information, but I'll probably expound on 2 to 3 things per slide. And while they're queuing up this video, I'll just tell you this doctor's going to be talking a little bit about age-related symptoms versus what are symptoms of Alzheimer's and other related dementias. And it's important to know the difference. A lot of the education programs we do, it's end up trying to get people to understand what's the difference between age-related and what's our disease symptoms of Alzheimer's.
In general, we talk about in individuals age 65 and older that people have perhaps an 8 to 10% risk of developing Alzheimer's disease over their lifetime. But it's clearly age-related. So if your family tends to live into their 80s and maybe 90s, your risk is going to go up rather dramatically. On the other hand, if people in your family tend to die in their 70s, the risk is lower. But it's clearly an age-related phenomenon, and with baby boomers, now those individuals born between the years of 1946 and 1964, moving into their 60s, this is going to exaggerate the number of people eligible, so to speak, for Alzheimer's disease rather dramatically. Some people have indicated that if we do not do something for Alzheimer's disease, meaning delay the onset, slow the progression, ideally we'd like to cure the disease, but even if we have these modulating effects on Alzheimer's disease, it as a single entity will bankrupt the healthcare system as we know it, because there's so many people in that age who will need services, will need extra care, that this will bankrupt the system.
I think what's important to take away from that is where he's talking about the focus being put on the delay of onset of symptoms and the slowing of the progression, in addition to the importance of finding a cure for the disease. The Alzheimer's Association is the leading organization in research for Alzheimer's, and one of the things I'm talking about, especially in my public policy work, is we need to keep in mind that the work on how to delay symptoms is as important as the work being done on the cure. Now, we're all optimistic and want that cure, and we're doing everything we can to get it, but there's a lot of focus on the medications and approach to delay of onset as well. So this just lists typical age-related changes: making a bad decision once in a while, missing an occasional monthly payment, forgetting which day it is and remembering later, sometimes forgetting which word to use, and losing things from time to time. What folks don't look at that list and go, I've done that, I've felt that, and then those are representative of a lot of things that we hear, should I be worried about, am I developing dementia because of these things? These are typical related changes. Our biggest walk away for you is make sure that people are comfortable and encouraged to talk to their physician whenever they're experiencing anything close to these things. Because for the most part, what happens is people have a relationship with physicians a lot of times where they're not comfortable talking about what they're experiencing. They may be embarrassed about what's going on. If they're a caregiver and they have somebody that they're taking to an appointment, they may be in fear of what that person may say. The patient doesn't want them talking about it. So just the conversations in general of what people are experiencing is not happening, and therefore any intervention with medications that could help doesn't end up happening. So just having the discussion itself with a physician is one of the biggest focus that the Alzheimer's Association is putting on in this respect. This video will show you somebody that's describing some of the beginning symptoms that she experienced, and that can give you a perspective of what we're talking about.
I noticed there was a time when I was dialing the phone and the buttons were, I couldn't dial the phone. And so I went to the neurologist, and she said, they said they didn't. I did some tests, and they said it didn't seem that anything was different. But then a couple of months later, I noticed that not only could I not dial a phone, but I was having difficulties writing. I was having difficulty spelling simple words like of and the. I was falling a lot. I began to have accidents, like minor accidents, driving accidents. And at that time, my husband said, we're going to the doctor.
One of the things that Joyce listed was that she was having trouble with using the telephone, and knowing that anything that deals in sequential order, planning and organizing ends up being affected, so that's what she was referring to. When she's talking about trouble formulating words and communication with the of and the, that's pointing at aphasia. And if you're not familiar with what we refer to as the 4 A's of Alzheimer's, there's amnesia, aphasia, apraxia, and agnosia. With amnesia pointing to the memory deficit, but aphasia is what she's talking about. It can be either receptive or expressive, meaning that if you're having trouble understanding the words that somebody else is saying and the phrases and putting it all together, that would be receptive. If you're having trouble formulating your words and putting it together to speak to somebody, that's expressive. But most often what we're educating clinical professionals, everyone, about that is that somebody can be experiencing a mix of both of those things. So we don't want to ever think because somebody's having trouble with one or the other that they may not be experiencing some of receptive and expressive. And what's the number one takeaway of something that you can do? It's very unnatural in conversation for us to have a long period of time where you allow somebody time to process what you've said. If you're in a conversation and you stopped and waited for somebody for 10 or 15 seconds for them to give an answer, that would be an uncomfortable moment for you, probably. Just know with people with Alzheimer's and all related dementias, they need the time to process what you've said, but also sometimes the time for them to process what they're putting together. And maybe one of the worst things you can do is rephrase a question. If you've asked a question of somebody and they're having trouble formulating the answer, it may be that they're trying to define the vocabulary that you just said and put it all together. And now what's natural in conversation is to rephrase things so that somebody may understand you better. Somebody with Alzheimer's, they're just now having to figure out what are these new words that they've now said, and now have to figure out how to put those together, and you really hit the reset button. Now they're going to need another 10, 15, 30 seconds. I've had clients in the past that needed up to 20, 30 seconds to answer, and they were able to, but they needed a long time to do that. Apraxia is when somebody's having trouble with motor function because the part of the brain that has the memories of, say, how to dress yourself, maybe the memory that I need to put my arms up to put a shirt on, that memory is now gone, so now the whole process of dressing has been affected because of apraxia. Agnosia we're going to talk about more when I give a different example, but agnosia has to do with it you're starting to have trouble recognizing objects. And I'm not going to jump the gun on that one because I have an example of that. But being familiar with all of those terms will help you understand the diagnostic criteria for Alzheimer's. She did touch on driving. Know that driving will be one of those topics that comes up with anybody you're working with Alzheimer's or other dementias, that families struggle with how do I end up addressing when's the right time to take the keys. That's the phrase we hear a lot. Well, know that if you'll focus more on the person's insight sometimes as to rather than their abilities, you'll see if you focus on the fact that they may not understand in an early stage of Alzheimer's of why it is you're doing what you're doing, even though it's going to be a difficult conversation and the person doesn't want to give up their keys, if somebody has the insight to understand what it is you're doing, it may be easier than waiting till the disease progresses more and they feel like, say, you're trying to steal my car and that's why you want my keys, because they've gotten to a point where they're experiencing delusions and thinking of that they're being stolen from. So I just encourage you to think about things a little more in insight perspective rather than always about abilities and where somebody's at. It's just a different way of looking at it. Problematic changes, memories changes that disrupt daily life, challenges in planning or solving problems, difficulty completing familiar tasks, confusion with time or place. I think I'll choose not to read all of them off. That's a lot of text, so you can read those. But there are a couple I wanted to touch on. The very first one says memory changes that disrupt daily life. So it needs to be a significant change from prior level of functioning for us to make a diagnosis of Alzheimer's. If you skip down to where it's saying new problems with words and speaking or writing, that goes back to what we were talking about receptive and expressive aphasia. Decreased or poor judgment. No, this is what makes people susceptible to scams. It makes people susceptible to financial abuse. Elder financial abuse is a huge problem, to where somebody may have no recollection even of the fact that they were scammed the day before, and today's a new day and that same person calls wanting to scam them and does it again because the memory deficit's there. So that's a big one to keep in mind. At the very end it says changes in mood and personality. Anybody that's worked with somebody that's had a cardiovascular atrophy or stroke is probably familiar with the changes in personality that can happen as a result of that. Well, no, in Alzheimer's and related dementias, you can deal with the same thing, that there may be a change in personality and mood and irritability, agitation, those things. To give you that different perspective, I want you to walk away with a family that says, well, mom's not mom anymore. This is not the mom I know, and their whole mood and personality has changed, and they're saying things to us that they never said before. And sometimes what I need to put in perspective for families and caregivers is sometimes the edit button, if you will, is starting to be affected, that it's not so much that they're saying things totally different, but things may be coming out that are opinions that they've had for a long time, that they're starting to come out because they're not editing what it is they're saying. So why am I pointing that out? Yes, sometimes somebody is getting to the point where their personality is so different and they're acting in different ways that they can seem like a different person. But it is often comforting for families to learn more about the disease, that maybe sometimes the things being said aren't these totally new things, and that this is mom, and this just may be some things mom's saying that she chose not to say in the past because she was mindful enough to look out for our feelings on that. So when mom starts changing and is a different person, that's difficult no matter what. But the education you'll be able to give your patients, to use different words, your patients, your clients, there's so many different professionals watching us, know those points of insight and pointing out that people have support to learn more about these kind of things can be really helpful. Loss of cognitive functioning serious enough to interfere with daily functioning, changes in memory, language, thought, navigation, behavior, personality, mood, planning, and organizing. Know that with Alzheimer's, you've got to have some memory deficit for there to be able to be a diagnosis of Alzheimer's. In long-term and short-term memory terms, know that people's long-term memory stays intact much longer than the short-term. And people can have conversations where they're talking about things 30, 40, 50 years ago with great clarity. But if you're talking about what happened yesterday or what was had for lunch today, that memory's not there because the taking on the new information is difficult. We'll talk a little bit more on another example on that one. Thought, I did want to point out one of the criteria with Alzheimer's has to do with that somebody may be having trouble with abstract thinking. If you'll stop and think of what abstract thinking means, you'll understand my example. Some of the best nursing staff and the best long-term care facilities are the nurses that work very quickly and can get a lot of things done and still have the best approach and the most patience. But know that a nurse that comes into a room and has a personal connection with that person living there and says, wow, last night you wouldn't believe what happened. My husband gave the kids a 2-liter of Coke and candy, and they were bouncing off the walls and we had to peel them off the ceiling. Well, that will be one of those times you get one of those quote-unquote blank stares, or maybe even some of that unexplained aggression. And I say that way because they may be believing that you were abusing your children by throwing them against the wall and that they were on the ceiling and that you threw them down on the floor. And that's the way that they're perceiving what you're saying, because it takes abstract thought to understand when you say, I'm so hungry I could eat a horse, that they understand you're not really talking about that. And people with Alzheimer's start to lose the ability to have that abstract thought. So to bring it all together, in practice, these are the type of things you want to just stand back and think about when you are having some of the aggression or some of the behaviors happening. Is there something that I'm doing that may be causing this? And going back and reflecting on all these things is a process, and it's a practice. A lot of these things are unnatural ways of going, unnatural to our normal communication, how to work with somebody. But it doesn't mean it's not effective. It just takes practice. Planning and organizing, know that balancing a checkbook is one of the first things that people tend to see a problem with in family members if they don't see anything else, is that mom or dad or sister or brother has started having trouble balancing their checkbook, or bills aren't being paid and utilities are being cut off, things like that. Because balancing a checkbook involves a lot of things. It involves your memory that it needs to be done. It involves that a bill's due and it's time to pay that bill. It involves sequential and order. And a lot of things are touched on in symptomology that makes that difficult. So that's one thing that you would work with bankers on from our perspective, to know if you have somebody coming in that's starting to have trouble with their checkbook and they want you to help balance it, maybe that's something that you would want to look at as a problem with them. I use the term unexplained aggression, and I put quotes around it a lot. Managing behaviors is a vague term in that you don't manage behaviors, you try to keep behaviors from happening in the first place. Once you get to where somebody's being aggressive, you're now in a de-escalation mode. The only thing that I've ever been able to try to train people on when they say we need help with the aggressive behaviors is doing things on the front end, and it can be frustrating for people, but I always say once you're to the point where somebody's aggressive, it's too late. You have to worry about how do I communicate and change my approach in the first place. Reversible diseases that mimic dementia, and this lists several. The one I'd like to put a little focus on is the dehydration. And this can be an example that if you're a staff member that you'd like to train your staff on the perils of dehydration and how that can cause delirium, is the term, that mimics dementia. Think about this, especially if it's in a long-term care setting. We all have an image of a long-term care setting room that it's a common one. You look inside of a room and it's 2 single beds and a nightstands on each side, maybe a chair, and a large pink jug of water sitting on the tray with a straw out of it. Think about if somebody's starting to have trouble with either one or two things. Maybe they have some confusion and disorientation due to a urinary tract infection that can cause a lot of the same symptoms as in Alzheimer's, or they're starting to have trouble with an actual symptom of dementia, which is agnosia. If you'll think back to what we said agnosia was, that's when you're having trouble recognizing objects. If you're having trouble recognizing that that's a jug of water, what happens? They don't drink. If somebody doesn't drink, then what happens? They start to become dehydrated. If you become dehydrated, what happens? You end up getting a urinary tract infection, and so on and so forth. We could go down this line to the point where somebody's placed on antipsychotic medications due to a urinary tract infection because of the perception that they have Alzheimer's or some other type of dementia, and start giving medications when a thorough assessment would have figured out that they're just not taking in enough liquids because they don't recognize the jug of water is a jug of water. And you see how both of those can be caused by either something that mimics dementia or actually dementia itself. This lists several different types of dementia. The ones that I would like you to differentiate the most here is Alzheimer's versus vascular dementia. Vascular is one that I would like to see people talk a lot more than they do, because that is the thing that caregivers and people looking to take care of themselves better can do the most in exercise and diet and taking care of themselves to possibly keep something from happening causing vascular dementia like a stroke. Where people ask us, what can I do to avoid Alzheimer's? Unfortunately, we don't have research that points to specific things we can say, if you do this, this will help you from having the onset of Alzheimer's. So whenever we have questions about, if I eat a certain thing, or if I eat coconut oil, or if I follow the Mediterranean diet, or all these things, well, those are all things that are going to be good no matter what. And I suspect that a lot of those things may help with the prevention of onset of different type of dementias. But no, with vascular specifically, that's one that a lot of those things that I just listed will help prevent that. More rare types, at the very top there you see Creutzfeldt-Jakob disease. My grandmother actually had Creutzfeldt-Jakob disease, which is more commonly known as mad cow disease, where you experience a lot of the symptoms we're talking about that may be spread out over years' time in a very short amount of time, and that's caused by prions in the brain that could be caused by non-sterile surgical instruments, or maybe even a familial gene that luckily we found out I don't carry the familial gene to have that, but that can only be figured out at autopsy. But that's an example of things that we need to keep in mind, because I, as a mental health professional, was sitting there trying to figure out what's going on with my grandmother, and I'm overlooking altogether this disease because it's known as a rare disease. And I should have been looking at all the different causes and thinking about that was possibly one of them. So you can imagine how me, with the knowledge I have, having that happen to me, I try to really drive home to professionals the same thing could happen to you when you see the same symptoms a lot. You can make assumptions as to it's Alzheimer's when it actually could be several different things. Wernicke-Korsakoff syndrome. I just wanted to point out that that's results from thiamine deficiency that causes encephalopathy. Encephalopathy, am I saying that right? Encephalopathy. I don't think I am saying it right. Hydrocephalus is close to the word I'm trying to say. Just know that chronic alcoholism a lot of times is the cause of Wernicke-Korsakoff. And what I want you to walk away from that with is a lot of these don't follow the same pattern as Alzheimer's. They may have very different things going on, especially with dementia due to head trauma. If head trauma happens in one part of the brain, then that part of the brain may be the only part that's affected. and they may never see a progression like in other ones. So when you have family members talking to family members and saying, well, this is what my person I'm taking care of is experiencing, it can be very different when they're comparing if it is due to different types of dementia. That's why it makes it all the more important to have education like this. Mild cognitive impairment. Unfortunately, mild cognitive impairment is one of those things where physicians are doing their job and letting people know that they may have mild cognitive impairment, but that's not necessarily at the point where they need to assume they're developing Alzheimer's. They're just having some problems that are showing that we need to keep a watch on it. What we're most concerned about at the Alzheimer's Association is that if somebody is having symptoms that goes beyond mild cognitive impairment and families are saying, you know, we think this is getting worse, that an official diagnosis be made either by that physician, if they do believe it may be going on, or refer to somebody that will, because for many, many reasons we can't go into today, it's very important that people get the official diagnosis of what's going on, be it for resources that would be available to them through respite, things like that, because of the diagnosis that they have. Sometimes physicians are in a hard spot because they may be having a family member say, please don't tell them that they have Alzheimer's. We don't think that's the best call. We rather just have them think they're getting older. Where a patient actually could be in a place where they would be reacting better if they knew exactly what was going on in an early stage. So those are very tough calls for physicians to make, and we realize that. What I take this opportunity to say is physicians in trying to provide the support that's needed following a diagnosis is very difficult, with physicians having a lot of people to see in appointments, and trying to provide that follow-up support can be difficult. And that's why the Alzheimer's Association has physicians outreach, where you can call the national hotline, you can go to the website, and you can get a ton of information for patients. But I won't talk about our organization too much. I'll wrap up with some information like that at the end. This is a video that Steve actually gives us a perspective on somebody that's been diagnosed with younger onset Alzheimer's, meaning he was diagnosed prior to the age of 65.
But the types of things I noticed had to do with organizational abilities, mental abilities, and I was getting confused. I was finding it hard to plan, and there were two pivotal sort of moments that really brought this home to me. And the first one happened when I went into work one morning and sat down at my desk to plan out my day and couldn't figure out what to do, and literally sat there for an hour frozen and could not figure out what piece of paper to pick up first.
This video points out the challenge that we all have as professionals when somebody's diagnosed at a younger age as to how to provide the support that they need following diagnosis. And if you think about somebody that may be, let's just say, in their early 50s, and we have people diagnosed younger than that, but for the sake of example, they're in their early 50s, and people wouldn't assume that they were serious when they said they've been diagnosed with Alzheimer's. That's not somebody you can refer to a local support group, where they would go to that support group where there are caregivers of typically possibly people in their 70s, 80s, and 90s, that the caregivers are getting support for each other in caring for somebody with Alzheimer's. This is somebody that has a job. This is somebody that has a family. He's still working. He's concerned, is my employer going to find out that I have Alzheimer's, and what's going to happen? They face much different issues and require a different level of support. So social engagement with other folks that have diagnosis is important, and us listening to them as to what it is that they need at where they are is important, because like I said, there's a level of confidentiality confidentiality is important with anybody that's diagnosed, but people with younger onset a lot of times will say to us, it's very important that this doesn't get out on my diagnosis. I'm trying to still figure out what it is that I'm going to do. Alzheimer's disease is a brain disorder, is progressive, and you see toward the end is eventually fatal. What I'll choose to point out here is that any professional that I saw listed as possibly on this call needs to prepare themselves for how to answer the question, what's the difference between Alzheimer's and dementia? It's the most often asked question to us. And my common answer is to point out that Alzheimer's is a form of dementia, but it's only one form. And we already listed off several of the forms of dementia, so I won't restate those. But people just need to know that Alzheimer's is one type. They may like for you to talk about that. We don't know definitive things you can do to avoid Alzheimer's or to slow progression, but know that there are criteria that we can use to figure out and diagnose if it's Alzheimer's versus the other ones, and it involves a lot of differential diagnosis. But they need to know that Alzheimer's is only one type and there are several other ones, because sometimes we're talking to people that they may have been gotten a diagnosis of dementia, somebody they're caring for, but the physician isn't sure exactly what's causing that yet. And can you imagine if somebody had been told that your family member has dementia, but we're not sure what yet, we need to do some more tests? And I can only imagine what it's like to have a day even go by to a week where you don't know more about what's going on. So pointing out that it's one type, but it's not the only type is very important. I don't have a lot of things to expound on this slide. This is just pointing out that there are the nerve cells or neurons creating a branch network that's affected, and neurotransmission is affected. In seeing this picture of the brain, I would just point out that anytime that you can have this on a wall in an office, or even have a model of a brain that actually comes up on the next slide, I think, to be able to give somebody a different perspective to think about what's being affected in the brain, because they're trying to figure out why it is that my family member is doing this, or why it is that they're doing that. And they need to realize that depending on what stage somebody's in the disease, which we'll talk more about, as to what parts are affected. And them seeing this does help put it in a little better perspective for them, that all different areas can be affected, and as progression happens, it just depends on which area of the brain is being affected as to what happens. This is the model I was talking about. People being able to see a model of a healthy brain versus an unhealthy gives them that different perspective, and that you keep talking about things that are happening to the brain, but if they actually see that the brain shrinks, that there actually is shrinking going on, that can give them a perspective. Okay, I understand. If the brain's literally having shrinkage, I can understand why we're having problems. In this video, Kitty gives a really good example of what was going on with her husband. It's a little bit longer video, but only maybe a minute, but a very good example.
Bill had been a graduate student for an advanced degree, and he found himself having difficulty defending his thesis, the last thing that he needed to do. Then he started making mistakes at work. We both somehow knew before he was diagnosed that something was very wrong. At first, we hoped it was something that they could either operate or cut out or burn out or something, or maybe he was depressed. Maybe he just needed a nice weekend and it would be fine. And then we realized maybe something's really very wrong. And it was. We went through several doctors, several unsuccessful attempts at getting some sort of diagnosis. Each time they would test Bill, he would ace their tests. If they wanted him to count backwards by 3, he could count backwards by 3.25. His problems were very, very subtle. And when we finally realized he was laid off from work, and I'm sure that was part of the reason why he was laid off from work. But during the election, when we elected a brand new president, although Bill wasn't working, he wanted to be active. So he volunteered to work at the polls. And he was an officer of the election. And before he left, we were very, very excited about it. It was a long day. It was 5 o'clock in the morning. And we knew no matter what happened, it was going to be a historical event. So we were very, very excited. We would either have a female vice president or an African-American president. One of the two, and it was going to be huge. So we were excited about it. He went off, worked at the polls, came home and told me, and we were very animated, talked about the people all the way around the block waiting to vote, and we were so excited we stayed up and watched the acceptance speeches, and we found out who won. And we thought that was just amazing, and it was history. So the next morning, he got up, and Bill said, I got to get the paper. I said, why? And he said, I got to see who won. And we both realized, uh-oh, he lost the whole day before because it was such a long day. And that was when I realized how serious it really was.
So this example points out the difficulty with taking on new information that I referenced a little bit earlier. To apply this, you'll have family that you're supporting, people with the disease, that in their whole treatment team, everybody needs to be on the same page that trying to get the patient to do something different by suggestion or direction is not going to work. The ability to do that is not there, or at least being heavily affected. So having the expectation of you need to do this, you need to do that no matter what, and I guess I can give an example. Maybe somebody that is trying to figure out, how do I keep my husband from falling? You know, we're at home and I can't be there every second when it goes to get up out of a chair, and I'm worried they're going to fall, and if there's anything I can do, I'll do it, but if I, just by asking him not to, it's not working. And when I put an alarm on the chair, he just rips it off. So that's a good example of knowing, going to them and saying, you need to not be doing this, you need to ring this bell anytime you're about to get up. Any of those directions, it's going to be difficult because they're not going to remember that you gave the direction. And even if from minute to minute they're remembering, it's not going to be something in the long term that'd be good. So it's a difficult thing to do, but trying to navigate those things with ways that you can respond differently to figure out ways to address it is always going to be more effective. A common question that we get asked is, how do I have a good visit with my family member, be it they're at an assisted living, a memory care unit, long-term care, no matter what it is. Our biggest suggestion is to look at that communication. As you see, I stay on that a lot, and ask questions like, are you only talking about how are they doing, and what did they do earlier today, what did they have for breakfast, and did you read the paper this morning? Those are very natural ways of communicating when you have regular visits with somebody, but those all rely on short-term memory that's difficult. So the more you can have conversations that deal with things that happened 10, 20, 30 years ago, the more comfortable and more able the person is going to be able to engage in conversation. The problem is it can be very boring for the family member to have the same conversations, or at least always be trying to talk about things that happened far in the past. But if they'll just realize that it's not so much about the content of the conversation as it is, how can I make it a lot more easier for them to engage in conversation, period. And for the most part, if people try those things, it ends up working a lot better. The primary risk factor is age, and an important point is the incidence is higher in women, largely due to women living longer. And then it talks a little bit about things that touch on genes, but there are two categories of genes. I want to take this chance to tell you a little bit about genetic testing and things to keep in mind if somebody's interested in having genetic testing done to know, do they have the gene, which is APOE4, that would make them at a 50% higher likelihood of developing Alzheimer's rather than somebody that didn't have that gene. My recommendation is always to think about why it is that you're having the testing in the first place. And that's not to point at don't have the testing or deflect people from doing it. That is not at all my point. But you do want people to think about, am I getting this testing because I want to make a change in my life? Should I find out that I have that and make the most of life? Or am I going to take this information and shut down? Should I find out that I have this gene and it doesn't matter what I do anyway, I'm probably going to develop this disease? I think it's a perfect reason to get testing if you want to know, to be able to inform family members, especially if you have children, that this is what we're dealing with, that we have this gene and we want everybody to be informed. But also keep in mind that some people will take information and react in a different way. I just want people to be informed and take some time to think about why it is that they're getting testing. Again, not to deflect the importance of genetic testing and that it can be a good thing. Just give it some thought. Selecting a doctor. Doctors can diagnose Alzheimer's with accuracy. Start with a physician who's experienced with diagnosing Alzheimer's. And then you see the positions it lists at the bottom. My big point is especially working with families, is for them to work with somebody and ask questions. If they're going to get a new physician, ask, are you comfortable with prescribing the medications that are the cholinesterase inhibitor drugs, which we'll talk about in a minute? Are you comfortable prescribing those medications if they're needed? Because we've heard that those are things that are prescribed for Alzheimer's. Are there any concerns you have of treating my family member because they have Alzheimer's? These are all things that, of course, the association helps people with asking when they go for doctor's appointments. Because physicians, for the most part, have been very open with me when I worked in geriatric inpatient psych to say, not all, but some would say, I'm not comfortable prescribing medications at any higher dosages than the first initial dose when it comes to cholinesterase inhibitors. I'm just not as familiar with what I should be doing with those, and I'm not comfortable with those. Well, I, as a family member, would want to know that, because that's one of few things that can be prescribed that can be helpful. So taking some time to ask questions is good for people when they're especially trying to get a new physician. Keep a log. Write a list of symptoms. Be specific. Include when, how often, and where, and develop the list with input from other family members. So these are things that we're telling families to do, that they may show up in your practices with a log, because we say this a lot. Now, I was lucky when we were helping people that are on an inpatient psychiatric unit that we were able to see what behaviors happen and what people's demeanor is like at different times of the day, because they're there 24 hours a day for that stay. But it is difficult for clinical professionals of all kinds and social workers to try to figure out what exactly is going on when they're only seeing people for however long that they're in front of them. If somebody keeps a log, it's much easier to see, okay, well, this is an example of sundowning behavior, when somebody's having more trouble and agitation in the later hours of the day rather than the morning. And with doctor's appointments often being very short, if somebody has a log, then it's all there to review either during the appointment or even after the appointment. So know that we encourage families to keep a log and share that with medical professionals. And a lot of times families aren't thinking about all the different medications somebody's taking and forgetting that the vitamins and the herbal supplements all can have a lot of effects, that they don't just need to list the doctor prescribed medications, but everything that they're taking. So this outlines the steps in an assessment. The part I wanted to put a little focus on is there it says mental status evaluation. Now, I'm familiar with the mini mental exam, a 30-point test, and a lot of, to determine level of functioning, mild, moderate, or severe problems. A lot of organizations are coming up with different diagnostic tests that are much like the mini mental exam. If you're familiar with that exam, I think it's really important that families, people being diagnosed for the disease, anybody in that group, to be told that that test is a great way to determine if there's some level of problem. But it's not a way to figure out if you get a certain score on this test that you have Alzheimer's. Because I can't tell you how many times I've been told, well, I told they got this number on the mini mental exam, so they have Alzheimer's. And I try to tell them that test is only trying to give a gauge of where they are in functioning to be able to share that information amongst a treatment team. That's very important. Now, the mini mental exam, again, to make sure we understand what I'm saying, is a great test in that it's very surprisingly accurate of telling if somebody's having mild, moderate, or severe difficulties. But families a lot of times don't understand the test. It's good for them to have more info. Down at the bottom, you see what it says, psychiatric evaluation to rule out emotional causes of symptoms. With depression and anxiety especially, if somebody was to have a diagnosis of major depression long-standing, we know people can have hallucinations as a result of the high level of depression they have. Well, what if somebody has a long-standing diagnosis of major depression, has had it for many, many years, and now they're starting to have some trouble with cognitive deficit? So we need to take in consideration that what they're experiencing may be due to the depression that's got worse, or maybe it's a mix of both. But that takes a good assessment of what's historical that they've dealt with and what carryovers now into also when they may be having symptoms of dementia. So when the diagnosis is Alzheimer's disease, and this slide just really leads into the next one. Families are dealing with all these things. And the best perspective I can bring as to when I was dealing with families that were trying to make a decision on whether they wanted to have their family member go into inpatient geriatric psychiatric care for a temporary stay. They're experiencing all these things, and probably the one that I would have flashing if I didn't have any other one was the word guilt. Because even when people feel that they're making the right decisions in the care of their loved ones, and it involves with something like going into a psychiatric unit, there's a huge feeling of guilt most often, even when they've got to the point of, in the bottom right there where it says acceptance and relief. I would be having families with me that were multiple sisters and brothers that are trying to make decisions for their mother or father, and they're going through all of these things all at the same time. And guilt is just the one that we need to realize, even if we've done our job, to point out all the options that are available to families and what they can do in making these very difficult decisions. Even if you've done your absolute best and they thank you and for all that you've done to support them, they still a lot of times have a large amount of guilt, and that's not something that we'll be able to resolve maybe right at that moment. You may have taken away a lot of these other feelings by your approach and doing all the things that I'm talking about, but guilt is a very tough one. I just wanted you to realize families are dealing with a large amount of. Stages of Alzheimer's. This outlines the early, middle, and late stage symptoms, and I'm going to run through these really quickly. Recent memory loss, difficulty managing money, driving, or handling social situations in early stage. Middle stage, difficulty with language, problems keeping track of personal items, and may need help with grooming. And in late stage, long and short-term memory affected and needs care around the clock. What I'd like to say about stages in general is it is very helpful to a family to know where their physician/psychiatrist, psychologist feels that they're falling, whoever they're seeing in their treatment team. Where do they fall on the spectrum of early, middle, and late? Because again, families are all the time trying to talk to family and friends that have also had family members with the disease, and they want to know, where am I in relation to what you dealt with? Because they're trying to prepare for what's to come. They've heard all these things that are going to happen, and they want to know, where are we at? I would just say that if a person that's overly concerned about trying to absolutely identify where they're at, just have them know that everybody's different. It's okay, in my opinion, to be saying, your situation may be very different than your friend that had a family member with it, and what their physician considered middle stage, your physician may consider early stage. There is a little bit of subjective thought on where people fall. But I think helping them identify if they're in early, middle, or late is important in providing them support and being able to talk amongst all the people they may be seeing. Because a lot of times people are seeing a physician, but they're also seeing a neurologist. So between those two, they should be on the same page. This is a specialist that gives you a perspective on planning that I think is very important.
One of the things with respect to caregiving, and a lot of patients, families, and I count myself in this group, we're baby boomers. We're used to things the way we want them, and everything's conveniently disposed of, arranged, whatever. But it's not so easy to try to take care of your aging parent who lives 5 states away. And one of the things that most of us have not dealt with is who's going to take care of mommy, who's going to take care of daddy, how am I going to manage her business affairs, who makes decisions for what she wants to do for her health care. I don't think that those are decisions and discussions that most families have early enough. We have them in crisis, but we don't do them early so that we know what the game plan is. And if there's anything that I think that all of us should do is have a discussion with our parents, both of them, one of them, whichever one is available, early enough on to say, how do you want things to go if this happens to you?
On this slide, this is going to refer back to what she just talked about in the video, where it says get legal and financial issues in order. If you remember when I'm differentiating insight versus abilities, this is another one of those where if somebody's trying, say it's a daughter and her mother, and the daughter's trying to get affairs in order for her mother that now has, let's say, early to middle stage symptoms. And her mother still has the insight to know my daughter's looking out for my best interest because I'm having trouble handling my finances. And as much as I don't want my daughter to have my checkbook and to be handling everything that has to do with my finances, I know it's the right decision. That's still a very difficult situation, but that's nothing like the situation when somebody's in moderate to severe stages and they believe that others are stealing from them, and they believe that the one that's providing the most care and support, which is the daughter, is the one that is stealing from them, because that's the person that's in front of them each day, and that's the only person that they know to blame, the one that's in the house where the checkbook is. So again, getting families to understand when they're asking questions like, how do I know when's the time to do that? We hear that a lot. When is the time to talk about them about driving? Based on you as my physician, when's the time that I should be doing these things? The more you get them out of the level of thinking of what are they able to do, and the more about where their insight level is, the more they put the pieces together to make a decision on their own that maybe as soon as possible is probably the best time. Because the last thing I want to do is tell somebody, well, this is the time. If they do this, this, and this is the time. Because it's different for everybody. But if they'll focus on the insight level, that can encourage them to do things as soon as possible. Educate yourself about the disease. Just for example, a family just knowing the difference between hallucinations and delusions is important, especially to learn more about that delusional thinking and thinking that things are going on that aren't happening is something that I don't need to challenge, because no matter how many times I tell them this isn't happening, it's not changing their thought process, can keep them from fighting and fighting and fighting something that they're not going to be able to change. And I'm keeping a watch on my time, everybody, don't worry. Cholinesterase inhibitors for mild to moderate symptoms. This lists a lot of the ones that are most commonly known, and Aricept and Exelon are well known. Residine is used a lot too, but you'll hear a lot of families talk about Aricept and Exelon and Namenda at the bottom. Acetylcholine is the neurotransmitter that ends up being affected, and the enzymes are called cholinesterases that break down the acetylcholine. So the idea with these medications is to help the process that's being affected. Families will report a lot of times to us that the medications were very helpful for a certain amount of time. If it's been explained to them exactly what those medications do properly, then they know, okay, these are things that may be helpful. We don't know exactly how we're going to react to them taking these medicines, but they can be effective in the short term. I think it's important to explain that, because I have had a lot of people come to us and say, well, we got a diagnosis of dementia, either be vascular or Alzheimer's, whichever type, but now we have this medicine, Aricept, and that's going to take care of it, and we've seen a lot of improvement, and we think if this is what we're dealing with now, we'll be okay. And it's an indefinite feeling of now they have this medicine that this is going to help. And I think you see where I'm going. That eventually those medications, because of the progression of the disease, aren't able to be effective. So education on what the medication is and what the result is intended to be is important. I think in this slide he's actually talking about a little bit of what I was talking about. I think that's a video.
So what can we expect from these drugs? Primarily, we can expect that they may improve your learning and memory a little bit. They may improve your word-finding abilities. They may improve a person's social interaction. So there may be behavioral effects as well as the cognitive effects of these medications. But generally, they improve the overall situation to a certain extent. Now, is that in fact effective? We think so, but it's modest. In some people, they may not notice any particular difference. On the other hand, in some individuals, they may preserve their function for a longer period of time. However, these are not disease-modifying therapies, so they really don't have an impact on the overall outcome of the disease. Nevertheless, they may be very useful in the short run.
This slide is talking about clinical research studies. Another takeaway about clinical trials is a lot of times families aren't aware that clinical trials are available to them or that clinical trials are even existing in their area. And a lot of times we'll hear from families, we'll do anything that we can in our power to be supportive of the cause to have this not happen to other people. And we want to do anything we can do to support fundraising efforts to find research dollars to keep this from happening, find a cure. Know that the Alzheimer's Association has a service called Trial Match, where if people go to our website, they can sign up for that. It's a free service where you find out more information about where the clinical trials exist in your area. Probably the best walk-away here on this slide, in addition to what I just said, was that families need to realize that they themselves are the ones that a lot of times the studies are looking for, and not necessarily the person with the disease. Researchers are trying to study family members to study more of the genetic link. So family members find out, oh, well, this is something that I myself could be enrolled in, and they're very eager to get involved, but they may just not realize that. This slide lists a lot of different services that we have. I'm by no means going to run through all of those. I will focus on the toll-free hotline and the website. Know that that hotline, it's active all the time. So family members say that have a spouse that they don't necessarily want to ask questions around a spouse, that they would be willing to stay up till 1 or 2 in the morning if they could talk for an hour with somebody. They can call that line at 1, 2, 3, 4 in the morning. If the person answering the phone can't answer the question, which they are trained to be able to handle most questions, but if a situation is more intricate than that person answering the phone can handle, they refer directly to a master's level social worker or a therapist that can talk with the person. And then you see alz.org. Our website's very robust, and I encourage anybody to go there, not only to download information for people they're supporting, families, but to get more education themselves. This lists some of the other things the Alzheimer's Association does. I will just point out, since I already talked about Trial Match and alluded to the fundraising events like Walk to Alzheimer's, that we have tons of volunteer opportunities, but also advocacy plays a large part in what we do. My job title is Director of Programs and Public Policy, so we're working with both federal and state legislators to encourage bills to go through and make that happen, as well as working with public health, which makes this opportunity today great to be able to work with Alabama Public Health. This is our last video, and then if we have a minute or two, then I guess there may be a possibility for a question. I'm not sure where we'll be at, but I do want you to see this video in closing.
I think it is important to reach out to the Alzheimer's Association. They have information to help you plan and think through the critical steps that you need to take on immediately, and I think that's very important. I also think it's important to reach out and build the community of friends and family that will be there to help support you as you go through that. It's a critical disease that can't be done alone, and you can't care for a person alone in that process. There's too many stories about the difficulties that that brings. So I think early on it's important for you to build that community and those relationships so that you know you have people you can call on to help you when the time is there.
What she's referring to in communication is the more when people reach out to us, and they may be reaching out to you and asking those first initial questions of, I don't know what I'm supposed to be doing, I don't understand what's going on, I don't know about this disease, the more you're not only, and we not only are giving them direct answers to those questions, but also encouraging them, there is support out there. There are support groups. There are people that you can talk to learn more. You're not in this boat alone, which is the biggest comment I hear somewhere in the conversations. I feel like I'm dealing with this all by myself and nobody else could be having as much a problem as I'm having. You know, a lot of caregivers are in their home 24 hours a day, not able to leave, don't have people assisting, and they can feel very isolated and not knowing that there's all the support available to them. And of course, with me representing the Alzheimer's Association, we represent a ton of support not only to families, not only people diagnosed with the disease, but physicians and clinical staff as well. But there are also lots of other organizations locally located that we connect people with as well. They don't know a lot of times all that's available to them, and it's important to do that in addition to educating them on the disease that we're helping them with as clinical professionals. I don't know exactly where we're at, but it looks like maybe we're at 1 o'clock.
Jason, thank you so much. I don't think we have a question at this point. If you have any questions, please get those right in. We have just a couple of minutes as we wrap up. Thank you so much for that just incredible information that you provided for us. I've been a nurse for quite a while and don't have anyone in my immediate family with Alzheimer's who has had it, but I've had some very dear close friends who are colleagues who were medical professionals, and I'd done some studies, and it was interesting to me some of the things I picked up on, particularly one friend recently who was dealing with her mom, and even though she was a medical professional herself, that level of denial that we all have for various things, how she didn't see some things. Her mother had a strange personality anyway, and then early on there was a little bit of dementia, not sure exactly where it was coming from. But one of the things she alluded to was, and today's Groundhog Day, that her life was there for a while like Groundhog Day, because her mom had no short-term memory, and they found themselves very frustrated. Even though she knew the disease process from a professional side, when she was dealing with it as a daughter, it was quite different. So that's just one of the things I've observed, that if you're a professional, take a step back. Sometimes we need somebody else to walk alongside of us and really help us just like anybody else, because that's our family member. One of the other things you said I thought was just one of the real golden nuggets I took with this was talking about the insight level. That was interesting to me. That was something that I had not been challenged with before, but I think that is a great takeaway for all of us to look at that insight level with those folks, so that perhaps there's some things that can be done early on in the process, so that when they get to that point when they're combative and there's no rationalizing with them on a particular issue, you would have already settled that. So I think that is one of the golden nuggets that you gave us. I hope that all of you have picked up several. I don't think there's any questions now. Thank you again for all this great information that you provided for us. If you have any questions, please send those in by email, and we'll forward those on to Jason. He's given us lots of resources to look for. And if you have any other educational needs, hopefully you'll check our website, because we have lots of programs coming up from time to time. And thank you again for joining us at the Alabama Department of Public Health Training Network.